ahead and get started. Dr. Torres, of course, drives from Dallas. I'm a Fort Worth girl, so I don't like Dallas traffic. He asked me if I needed a microphone, and I told him I was a loudmouth. So can y'all hear me? Okay. I want to thank you for coming. We do have some COPD folks and some, I think mainly pulmonary fibrosis patients. You do not need to raise your hand to say what you have. September is Pulmonary Fibrosis Awareness Month, so we're winding that down. Those of you that are affiliated with our support group or PF Warriors, you guys are connected pretty well and kind of figuring out what's been coming down the pike. Remember, the reason that we do support groups is so that we can join together with a commonality, which is having a compromised health condition. In our particular situation, this lung disease. Unfortunately, the last 3 years, I was telling Dr. Torres that we have seen an increase in folks coming in with a referral of the diagnosis of pulmonary fibrosis. And there are several reasons why, and I think a lot of that we're going to discuss today. So COPD folks, don't think we forgot about you, okay? But I think from our experience in the years I've worked in pulmonary rehab, the majority of our folks that have been lung transplanted patients through Dr. Torres' group are people that have IPF. Okay, so it's an area that's getting a lot of awareness, and I am very fascinated because the better I can educate myself, I can educate you as well. I want to thank Dr. Torres for taking care of, because you guys are my patients too, and they can be a handful. that one. So anyhow, I'm going to go ahead and turn it over to Dr. Torres so he can get started, and then there'll maybe some time for questions. I'll let him kind of navigate through that, and then we'll finish up.
Thank you, Esther, and thank you guys for inviting me to talk about lung transplantation. It's amazing. I started doing lung transplantation back in 2000, well, 1998, really, when I was in Denver at the University of Colorado at the National Jewish Center. There I was doing my fellowship, and I got it was kind of neat because I saw that whenever there was a problem, a patient not doing well, all my attendings will call the lung transplant doctors and say, hey, what else should we do? I look at them and say, why am I working with you guys? I'm going to work with the transplant docs. So I did 2 years of fellowship just doing lung transplantation, and then I moved to Dallas, to what used to be St. Paul. And I was doing lung transplantation, but we were doing only 10, 15 transplants a year, so I was kind of bored. So I went ahead and started building a pulmonary hypertension clinic. And that's how Tammy got to me. I started building the pulmonary hypertension clinic, and it kept on getting bigger, and lung transplantation was steady. We were doing about 10, 15 transplants a year. And then over time, the pulmonary hypertension became so big that I gave it to Dr. Shing, and then lung transplantation. I took over the lung transplant program about 5-6 years ago now, 2010. And then we started building the lung transplant program, where we noticed that patients were dying in the waiting list, or they were not being placed in the waiting list. And I felt that we could do better. We should do better. In Texas, in North Texas, we should be able to help more people. And over the following years, we went from 15 to 25 to 50 to 60, and and this year we have done 60 lung transplants. So hopefully we will be able to help 70, 75 patients by the end of the year. So that's my story. But when everything else fails, when all of our medication fails, lung transplantation is the safety net. Why? Because after lung transplantation, we cannot help our patients with anything else. So most of you are familiar with the UT Southwestern complex. These are the North Campus research buildings over here. Across the street is Clemens, the new hospital. And then the clinics are down here. And we're building, this is St. Paul that was demolished, and that's where we're building the new outpatient clinics. So there'll be 3 new buildings over the next 3 years. By 2020, the lung transplant program will be located in one of the new buildings. And then the medical school, the education for students, etc., is over here. Parkland and Children's are back there. So when we look at the history of lung transplantation, it dates back to 1960s when Dr. Hardy performed the first lung transplant. It was a disaster. The patient was alive only for about a week. And yes, transplants continue to be done here and there, but it was not until cyclosporin, an immunosuppressive medication that was not a steroid, was discovered that then suddenly, the lung transplantation became a viable option. By 1982, Stanford does the first heart lung, and then 83, we're starting to do lung transplant, and by 1990, bilateral lung transplants become available. At UT Southwestern, we did our first lung transplant in 1991 under Dr. Steve Ring, that now he's a consultant for us. By 2005, the patients are not placed in the waiting list by how long they have been waiting for a transplant, but how sick the patient is. And you will see that then suddenly, instead of patients being transplanted because of emphysema, COPD, patients are transplanted because they have pulmonary fibrosis. Why? Because that lung allocation score, what it does is patients who are the sickest get transplanted first, and those patients who can live and stay alive longer have a lower score. That's why we are seeing so many patients with pulmonary fibrosis being transplanted rather than emphysema. So, the different types of diseases that we get patients transplanted are the infected. If we could turn down 2 lights, Mary, yeah, that, perfect. I think that should do it, yeah. This is a patient who has cystic fibrosis where there are little cysts throughout the whole lung, and these are patients who have production of sputum all the time because of genetic disorder. When you look at CAT scan, you can see these holes, and those are bronchiectatic areas where the airway, because of the recurrent pneumonias, they become very dilated, and patients are coughing up sputum all day long. And over time, the lungs get damaged to the point where they're needing oxygen 24/7, and they're not able to walk from here to the car. At that point, we proceed with lung transplantation, and their lung functions also drop significant, FVC below 40%, etc. Whenever we do transplants, we have to balance or keep in mind some of the potential problems that that type of population will have. For example, cystic fibrosis kids, they are 30, 40 years of age when we do a lung transplant. They have been sick all their lives. What does that mean? That we all were teenagers, didn't we? Didn't we do stupid things? Well, they never went through that stage because they were sick. So suddenly you put 2 new lungs in them, it's party time, and we have to calm them down. Hey, you cannot be doing that, etc. So, but no, joking aside, they tend to suddenly have a new life to the point where they're young and they want to experiment the things that we experimented with way back, and then they can tend to get in trouble. But they can develop diabetes and certain infections that we cannot handle. There is a patient with COPD, emphysema, where the lungs are very big. You see black. Black means air without lung tissue. You can see air outside the chest. And there is a patient who has advanced COPD with flattened diaphragms and what we call a barrel chest. And these are patients who obviously are very symptomatic. They have shortness of breath. We see him here in the rehab area. And indeed, if you exercise and you have emphysema as your lung disease, those patients tend to do much better. They tend to come down the amount of oxygen, their endurance improves, and that's why we have a rehab place where we send our patients before lung transplantation, and we say, before we do lung transplantation, I want you to try to do pulmonary rehab, because some of these patients are going to do so much better. There was a study called the NET trial. It was patients who, back in the early 2000s, we were doing a lot of lung volume reduction surgery. Was that all these bad areas of the lung, we would take them out, and suddenly the lungs would become smaller, so the diaphragms then would become more of a dome shape, so patients could breathe much better. So the NIH said, we do not know if this surgery is good or not. So let's study it, let's randomize, let's put patients into lung volume reduction surgery, and let's do the surgery, and the other half, we're not going to do surgery. But before we put these patients through surgery or randomized to treatment, everybody is going to do pulmonary rehabilitation. And guess what? About 35% of patients at the end of the rehabilitation say, you're not cutting me, I'm feeling too much better. That's what put pulmonary rehabilitation on top of our emphysema treatments. Patients were doing so much better that we said, we don't need to put you through surgery. And then suddenly, all the patients before lung volume reduction surgery, before lung transplantation, go through pulmonary rehabilitation. And obviously over here, you have seen how good of a job they can do. So patients with emphysema will have holes in their lungs where there's a lot of patches of blackness, and that means no lung tissue. And patients usually, when their lung functions have dropped significantly, meaning below 25%, that forced expiratory volume at 1 second, that's when we start considering for lung transplantation. Obviously, this population tends to develop emphysema because they used to smoke, so they tend to be older. So we don't have that teenagers' years misstep. But they tend to be older, so they can have coronary artery disease, they can have damage, because they tend to be older of the kidneys, the liver, bones, etc. So we have to be conscious of that and look into it. One of the things about emphysema is that patients can feel horrible. They cannot walk from here to the car. It's a very limiting disease, but they tend not to die always. They are very limited, but we can keep them alive for a long period of time with poor quality of life, but they stay alive. That's why their lung allocation score, the placement in the waiting list, is lower. As we will hear around, the pulmonary fibrosis patients, we cannot keep you alive. That's why your score is so much higher. I have to transplant you quickly because otherwise you'll die in the waiting list. Make sense? Okay. And this is a chest X-ray of patients with lung fibrosis. Remember, the emphysema patients, the lungs are huge. Fibrosis, tiny. Because the lungs cannot expand. And that's why it takes so much energy to breathe. That's why you're short of breath. That's why it's easier to pant and breathe that way rather than taking deep breaths in and out. When you look at the CAT scan, there is a patient with usual interstitial pneumonia. You can see the scarring, the whiteness, thickening of the lung tissue throughout the lung field. And sure, patients with pulmonary fibrosis tend to be older. The problem we have with pulmonary fibrosis has an unpredictable pathway. You can be doing great and suddenly, boom, you end up in a breathing machine and we are fighting for your life. That's the problem with this disease. And it's a challenge not only for you, but for us physicians, for your doctors, your lung fibrosis doctor, Dr. Fitzgerald, Dr. Giraud, Dr. Glaser, Kershaw at the medical school. And what we realize is that as soon as you're diagnosed with this disease and you're starting to need oxygen, the lung transplant team needs to meet you. Why? Because we need to find out if you are one of those patients who are going to deteriorate slowly over time, or you are going to deteriorate very quickly. And if you are deteriorating very quickly, I need to know you. I need to have all the things in place to be able to help you with a lung transplant. Again, some of the concerns with patients with pulmonary fibrosis is that you can be predisposed to developing cancers, lung cancers. You also have been exposed to steroids, prednisone, for so long that your bones can be weak. And we need to know that beforehand and try to strengthen your bones. Control your diabetes, control your blood pressure. Make sure that if you have atrial fibrillation, that we can control your arrhythmias. Blockages in the arteries, we need to fix them with stents, etc. So the earlier we know about you, the more we can fine-tune before you need a transplant. Okay? There's another disease called pulmonary hypertension, damage of the blood vessels of the lungs, and these are patients who have developed pulmonary hypertension. And what you can see is the lung tissue looks good, normal, but it's just the heart starts getting enlarged. The blood vessels of the lungs are damaged. And these patients, the lung tissue looks good, it's just large blood vessels with pulmonary hypertension. And these patients, again, we monitor them very closely so that when they're deteriorating, then we can move them into transplant. And again, so in the waiting list, the patients with highest priority, pulmonary fibrosis, followed by pulmonary hypertension, then cystic fibrosis, and then emphysema, COPD. Has nothing to do with you smoke or did not smoke, or you deserve or you do not deserve, how good you are, how bad you are. It's all about the likelihood of you dying waiting for a transplant and the success of doing a transplant. That's the equation. Okay? So, in order to do a lung transplant, we need to make sure that it's safe for you to undergo lung transplantation. And that's why we put our patients through so many testing. We are going to look at CAT scans to make sure that we don't see a malignancy on the chest. We're going to do a cardiac catheterization to make sure that you don't have pulmonary hypertension or you don't have blockages in the arteries that we need to fix. We are going to do CAT scans of the abdomen, make sure you don't have a cancer in the liver, in the kidneys, in the lymphoma, spleen, etc. And we're going to make sure that your kidneys are working well, because if your kidneys get damaged, it's very difficult to keep you alive after a lung transplant. The liver function test, we're going to look at Dopplers of your arteries of your neck to make sure you don't have a stroke when you wake up after a transplant. We are going to do pap smears, looking for cancers in the uterus, etc. We're going to look for infections that you may not know about, like hepatitis, like HIV, syphilis, gonorrhea, etc. Illnesses that unless you're tested for, you will not know that you have that infection. And imagine if I give you a lung transplant and you had HIV. Well, suddenly I'm lowering your immune system even more. You're going to get a bad infection. Or hepatitis, and I lower your immune system. Suddenly the hepatitis can go get out of control. We need to make sure that psychologically you can tolerate a transplant. How much steroids do we give, Linda? A lot. And if you are very unstable with steroids, bad things can happen. I remember vividly, nice lady, and the husband calls me. Dr. Torres, you have to do something. What do you mean? She's doing great. Yeah, she just bought a red Corvette. And you have to be careful because our medications can make you happy, very happy, too happy. And suddenly you can start doing things out of control. So that's why we ask the psychologists to see a psychiatrist, etc. Lung transplantation is expensive. Yes, we may have insurance, but the copays can add up. Having the right insurance is essential because 10-20%, though it sounds like a small number, well, 20% of a huge number, it can become a big problem. So we have social workers, financial people who can guide you towards this is how much money out of pocket is going to cost. And that's why it's expected. And remember, there may be admissions that we have not accounted for, etc. So the finances have to be in place, and we have the finance team that meets with you to try to guide you through the process. There's some things that are relatively contraindication for a transplant, like osteoporosis. Your bones are weak. We have to fix them. We have to give you calcium, vitamin D to strengthen your bones. If you're too weak, well, if you're so weak that you cannot stand up and walk, it's going to be a problem because we are going to need you to cough hard, to walk, and to get out of bed after the transplant. So if you started so weak, you cannot do it. And that's why Esther and the team here helps you get stronger, getting ready for when you have the transplant. Yes, you're going to get weak, but you started so strong that you are going to jump up and be able to bounce back very, very quickly. We do not want you on high dosages of steroids. Why? Because the wounds tend not to heal if you are just on steroids. That's what happened to the first transplant. That back in 1960s, we were using high dosages of steroids as our immunosuppressive agent. Well, wounds never heal. So their anastomosis, the connections of the blood vessels of the airway, tended to fall apart. So 2 weeks, 3 weeks down the line, you would develop infections and the whole thing would fall apart. We don't want you smoking. We need to be off smoking and all tobacco products for at least 6 months. The first lungs got damaged because you were smoking. I don't want you to damage the next set of lungs. Drugs like heroin, cocaine, etc., they are no-no, and we'll randomly test for those. If you're on a breathing machine, that's a problem because if you're intubated on life support, you usually are sedated, so it's comfortable to be there. But that means that you're in bed 24/7. Your muscles get weak, and we'll show you what we're doing to go around that. You know, back in the days, we used to say if you're over 65 years of age, I'm sorry, we cannot do a transplant. But you know, about 6 years ago, I said, you know, this 8 years old patient looks better than my 63-year-old patient. Why should I say no to him and okay to the 63?
Room 405. Room 405. Room 405.
Doc, you don't have to go. You're fine. I got it covered.
But that's why suddenly we started shifting from your anatomical age to physiological age, where if you look about 65, but you're 70, you're 75, we will consider you for transplant. And about 3 years ago, we did a transplant on a 76-year-old patient. But guess what? The year before that, he himself built a house. So it's not a normal 76. And he's 79 years of age after transplant, and he's doing great. So after you pass certain age, everything has to be perfect. We cannot be having blood vessels that are narrow, that you can develop a heart attack, or your kidneys are a little bit damaged, because you will show your age after the transplant. And that's why the transplant, the absolute anatomical age is not as important as your physiological age. We are going to relative contraindications, certain infections, because there are certain infections we cannot kill. Certain fungi, certain pseudomonas, we do not have medications that can kill the organism. And then suddenly we put the new lungs in and you die because of an infection. Diabetes is a relative contraindication. You're able to control your blood sugars rate. But imagine if you cannot control your blood sugars today without steroids. Imagine when we do a transplant, we give you medications that can cause diabetes, and your sugars are very uncontrolled. You'll die from infection, you'll die from kidney damage, you'll die from other complications of diabetes. And obviously there are some illnesses that if you have that kind of medical problem, I cannot proceed, I cannot do the transplant. If your bone marrow doesn't make blood, when we give you our immunosuppressive medication, the side effects of our medications to lower the production of blood of certain molecules. Suddenly, you are dependent on blood transfusions all the time. We get in trouble. Platelets, we get in trouble. White blood cell, then you're prone to infection. So bone marrow disorders, for the most part, if you have bone marrow failure, we cannot proceed with transplant. Cirrhosis, where your liver doesn't work well, so our medications are cleared by the liver. Imagine the problem. You now have toxicity from our medication. So patients who need a lung and have cirrhosis, they need a lung liver transplant. And sure, we can do them, but also we need to make sure that you're a candidate for combined lung liver. Certain cancers are a problem. Breast cancer, lung cancer. You don't know that they're still there, and then suddenly you do a transplant and boom, they pop up. And usually, so that's why usually we want to wait 5 years for breast cancer, for lung cancer, for colon cancer. There are other cancers that we need to wait a little bit longer. Melanomas. Renal cell cancers are kind of strange because your immune system keeps them in check. So you may have a melanoma, we take it out, and you look for melanoma cells, you don't see them. But suddenly we lower your immune system and boom, it's all over the place. Why? Because they were just single cells spread through the body that we could not tell that they were there. But they were being kept in check by your immune system. As soon as we lower your immune system, then the cancer cells spread. That's the concern with some of these cancers, that we have to make sure that you don't have them and wait long enough to say, the likelihood of you having this cancer is very small, or the recurrence of this cancer. And even then, we get sometimes fooled. And suddenly we do the transplant, wow, it pops up all over the place. Infections like HIV, hepatitis, we have to be very careful, because if we lower your immune system, then it can get worse. I wanted to give you the example of HPS. It's a syndrome of some patients with lung fibrosis that is a hereditary form that causes interstitial lung disease, platelet disorders, can cause renal failure. And we are one of the centers who have done about 2 out of the only 11 transplants on this condition, and we have been very successful with it. But you remember how small the lungs could be with lung fibrosis, or very big with emphysema. This is a patient 8 hours after lung transplantation, then your lungs look pretty nice. You will have 2 chest tubes in each lung that had a transplant, and that's to drain air or drain fluid out of the lungs or around the lungs. The heart is in the middle and it looks very normal. So after transplant, you're going to be in the intensive care unit. And you'll be there probably 3 to 7 days. Linda, how many?
I think it was 12.
Oh, you're breaking our records there.
And then an extra 2-3 weeks for rehab.
You see? And she's still around. One thing that you have to, one message that I want to take, I want you to take home is that each one of you is going to be very different. Transplants are so different for each person. And just because one person is doing great and goes home in 7 days, that has no implication compared to one patient who is in the hospital for 3 weeks, 4 weeks. Depends why they're there, what's happening, and how they recover. So don't think, and that goes mainly for the family or relatives. Oh, the other patient that came in the same day for a transplant as me, they went home and look, my relative is still here. Has no long-term implication, just that you left or did not live that quickly. But most of the things that we're going to be looking at just after transplant is complications from putting the organ in and how your body, your blood reacts to that new organ. And you saw how pretty that chest x-ray looked before. This is a patient who has reperfusion injury. The lungs are, the body is reacting to the lung and is having reperfusion injury. And you say, oh my God, how is that patient going to do? This is a patient who had a right single transplant. The left lung is the old fibrotic lung. And that's why I tell my patients when they come to the hospital the first time and say, I want a double lung. I say, okay, why? Well, more is better. Or I have seen the statistics that at 10 years they have 10% increased survival. Well, imagine if both lungs look like that. How am I going to keep you alive?
You kept me alive. We're going to go along.
But your lungs did not look this sick. So when we do a transplant and something goes wrong, that native lung that you have there is not great, but it's keeping you alive. Well, it will keep you alive until I fix that new lung. While if I have done a double lung and both lungs have had that reaction, my hands are full trying to keep you alive until I fix those lungs. Other things that can happen after a lung transplant, in addition to that reperfusion injury, is infections. And certain viruses like CMV can be very mean and cause fluid around the lung and little scarring on the lungs. And this is a patient that when we did the biopsy, we see these red cells. And that's CMV infection. And that's why our patients, we put them on medication to suppress this virus so that it doesn't damage the lung. Other times we just see a little spot, that little kink. That little kink is just a little spot, and that's a fungus. And if we had not realized, wow, there's that little spot there, that fungi could have spread throughout. Obviously, we can have rejections, and symptoms of rejections can be shortness of breath, fever, tiredness, fatigue. But all of our patients are going to go home with speedometers. The blowing machine that you go and do that test, you take one of those home with you. And twice a day, we ask you to blow into the machine, and if your lung functions are dropping, time to come to the hospital so that we check you. This is a patient whose lung functions were dropping, and you can see all this little white stuff, grayish stuff. That's too much congestion in the lungs. And after we treat them, then the lungs look normal. And when we do lung biopsies, what we're looking is for these blue cells. These are blood vessel, and these are blue cells around the blood vessel. And that's immune cells trying to get rid of the lungs. Because the lung, that's their job. Your immune system job is to get rid of things that are not self. Bacteria don't belong there. Viruses don't belong in there. But guess what? That lung doesn't belong there. And its job is to get rid of it. And our job is to lower the reaction, the response of your immune system so that it doesn't recognize that lung. But at the same time, it has to recognize that mean bacteria, has to recognize that fungi, has to recognize that virus, and has to kill them. Now you can see how difficult this can be over time. And that's why you say, Dr. Torres, but you know, your survival is not as good as the kidney dogs, so you must suck. And in reality, if you really think about it, all the other organs, the kidney, blood goes into the kidney, blood goes out, urine goes out. The liver, blood goes in, gets clean, blood goes out. The heart, blood goes into the heart, gets pumped out of the heart. The lungs, blood goes in, blood goes out. But every single breath, air goes in, air goes out. Every single time you take a breath, you're exposed to your environment. From time to time, you're going to inhale something that your immune system needs to react. And that's the problem. Over time, that fight between reacting against a virus, a fungi, a particle, but not reacting against the lung, we lose that battle. That's why our survival is not as good as, let's say, the heart, the kidneys, or the liver. Okay? So, also we're predisposed to developing certain malignancies, cancers, types of lymphomas. So we look for those all the time. And in this patient, this is a patient who had emphysema on the native lung. The transplanted lung is on the left side. Where's the spot? Look at that little ball. Easy to miss. Absolutely. So when your doctors go and look at the x-rays, etc., we're looking for little things like that. But they can be missed for sure. In this case, we noticed that little spot. We did a CAT scan, and now it's easy to see. But we don't do CAT scans routinely, except when we see something abnormal. And this is a type of lymphoma that we have very good treatment for it. We just give an antibody and wipes out the cancer, and you're cured. Other problems that can happen, this is a normal anastomosis, the connection between the bronchus and the new lung. So the new lung is deep that way. And this is the blue stitches that we use so that we know where the new lung starts and where the old airway was. And here you can see the lumen is down here, and boom, a little hole. And that's that connection broke apart because of a little infection. And we have to go back to the operating room and fix it. So let's talk about lung transplantation survivals. How is it that we're doing? These are the number of transplants performed every year, and you can see that we have been increasing the number of transplants. We do about 3,000 to 3,500 lung transplants a year now. One thing that you will notice in that graph is that the number of transplants we are increasing the number of transplants that we do mainly by doing more double lungs. The survival over time we have been improving. The light blue line is the survival way back in the 1990s. Then the green is in the 2000s and in early 2000s, and then the red is after we changed that allocation score. So over time we are improving the survival of our patients. It's just at 6 years is where we have 50% survival of our patients. And that's why when you meet us in the transplant program, we tell you the life expectancy is 6 years. That means 50% of our patients are alive at 6 years. Do we have patients alive 20 years after transplant? Yes. But we also lost patients at 1 month. So it would be unfair to tell you, yeah, we'll keep you alive for 20 years. Because you can be that patient who is only alive for 1 month. So that's why we say 50% of our patients are alive at 6 years. When we look at the types of transplants that we do, historically we were doing more emphysema patients, and now we do more pulmonary fibrosis patients, and mainly we are doing double lungs, but from time to time we will do a single lung. Remember that chest x-ray that I showed you, there's really not that much big difference on survival, but if we get in trouble early on, that native lung can keep you going. When we look at survival depending on the medical condition for which we did a transplant, you will see that the patients who do the best are the cystic fibrosis patients. Then it follows the COPD early on, they do much better, and later on it tails off. And then the pulmonary fibrosis patients are the dark blue one, who is somewhere down there. And you say, Dr. Torres, again, you're shortchanging us. I have cystic fibrosis. Yeah, I agree. Why is that? Because cystic fibrosis patients, they have recurrent pneumonias. After a lung transplant, they don't get those recurrent pneumonias. Their immune system, we don't have to worry about anything but suppressing it. There's no driving force to continue damaging the lungs. But a pulmonary fibrosis patient, remember, something destroyed your lungs. Something that most likely is immunological that we do not really understand. We have not taken that away. Sure, we're lowering your immune system, so we expect or hope that that process is calmed down. But there may be things that we're not stopping just because we do not understand them. I did not say you're going to develop pulmonary fibrosis. I'm just saying there's inflammation. Your immune system has the ability to react to lung tissue in a different way than the cystic fibrosis or the COPD patient. And I suspect that that's part of the problem. Cystic fibrosis patients are younger. They don't develop the kidney failure. They don't develop the renal failure. They don't develop cancers. They don't develop blockages in the arteries of the heart. While the lung fibrotic patients, emphysema patients, all those things are out there, and we can develop them. And so other comorbidities that have nothing to do with lung transplantation can affect your survival. This is survival overall, depending on if you are alive after 1 year. You can see that cystic fibrosis patients do the best, then pulmonary hypertension, and then you start seeing alpha-1 COPD and pulmonary fibrosis patients to follow. So there are certain things that affect the survival at 1 year. How sick you are, meaning if you're needing dialysis prior to transplant, that's a bad thing. That's why we keep an eye on the kidneys before as well as after. Infections like CMV can be a problem. Hospitalization. If we did a transplant because you were so sick that you were in the intensive care unit on breathing machine, I can assure you, you have other potential problems. You can be very weak. You can have kidneys not doing that well, liver not doing that well, the heart may not be doing as well. And when we do the transplant, it may show, and bad things can happen. You remember that we mentioned about physiological age. Yes, it is true. The older the patients, the expected survival is not as high as the younger patients. But that's why we do 70 transplants a year, so that we can afford and take a chance on somebody who is older. I can assure you, I can make my numbers look very good after lung transplantation. I will not transplant anybody after 65 years of age. As a matter of fact, you have a little bit of kidney injury or a little bit blockage in your arteries of the heart, sorry, go somewhere else. But that would not be right, because it is true, your survival is not as good, but I can keep you alive for a while, or hope to give you a new life. And perhaps not make it 10 years, but maybe 5 years, and maybe not 6 years, but 5, etc. As you, and some of you have experienced having a lung transplant at UT Southwestern, what you realize is that the more, and it's different today than 10 years ago. Today, you walk in and everybody knows about lung transplantation, from the person who's bringing you the food tray, to the person who's cleaning the floors, to the nurse, to the respiratory therapists, to the dietitians, etc. Everybody's in sync. They know if I have a cold, I'm not going to walk into that room. I'm going to call my partner or my co-worker and say, listen, I'm sick today. I'm not going anywhere near the transplant patients. As you do more and more transplant, the whole institution works in synchrony. And whoever is not, there are other people who are in synchrony and say, that's not the way we do it. And you see how then suddenly what you see is that the survival of our patients improves. So it seems that 35 to 40 transplants a year seems to be that magic number where suddenly there are enough lung transplants being done in the institution where suddenly people are all in sync. Single versus double, we mentioned about it, that we are doing a lot more double lung transplants than way back. This is the same, oh, I see what happened. I'm sorry, duplication of all these slides. Now, so we talk about survival, and I wanted to share a little bit with you what is it that we at UT Southwestern are doing to help our patients. So one of the things I wanted to do was increase the survival of our patients waiting for a transplant. When I took over the transplants program, I noticed that, wow, there are so many patients dying waiting for the transplant, and we only transplant 10-15 transplants a year. We need to change that. So first step was we have to keep our patients alive. It is true. So we built dedicated programs, the pulmonary fibrosis, the interstitial lung disease program. Those are physicians dedicated to lung fibrosis. They're experts nationally. So if a patient has that disease, they know the best medications to put to that patient so that they are alive and they have a better quality of life. And they are the ones who tell me, Dr. Torres, we need help, this is not working. We built a pulmonary hypertension program where we have experts nationally recognized on pulmonary hypertension. If you have that disease, you have experts who are dedicated to giving you the best medications for that illness. Cystic fibrosis, dedicated physicians just to that disease. So that the patients are receiving the best medical care that they can for that specific disease. And when they feel, I cannot help you any longer, then that's when they're referred to the lung transplant team. We, the lung transplant team, are not the ones saying, oh, you need the transplant, without knowing that there may be another medication out there that can help you. The end-stage lung disease program, ILD, pulmonary hypertension, cystic fibrosis, are the ones saying, There's nothing else that we can do. So, improving the survival in the waiting list was extremely important. But then also, we need organs. End of story. It's just, we do not have enough organs. So, another decision was, we need to find technology to help us increase the number of organs available so that we can harvest more lungs and we can use more organs rather than saying this organ doesn't look good and then lose the opportunity to using an organ. And third, we have to increase the survival of our patients because at that time we were having a survival that we hope that we could improve. So you remember we talked about improving the survival of patients waiting for a transplant. Something that existed way back was a heart-lung pump. It was called bypass. We use that type of technology when we do bypasses. When a patient is having heart surgery, we take the blood out of the patient, we put it into a pump, oxygenate it, and pump it back into the human body. But that technology is used for 6-8 hours. And then we finish the surgery and the patient goes to the floor. Well, that's what that technology looks if you try to use it longer than 8 hours and you want to put the patient on a heart-lung pump and keep the patient alive for a long period of time. Well, you can see how much equipment is needed, and we were very unsuccessful on keeping our patients alive. I remember we were never able to keep a patient alive more than 5 days when we were using that technology. Whoops, this is what came up. All that equipment got simplified to that. The cannulas were made better. Now we didn't need to use as many blood thinners. They didn't get as infected. The oxygenator became tiny. The heart pump became small. So suddenly, we were able to keep patients alive. We have kept patients alive for about over 30 days on that technology. Well, that gives me some time to find a lung for you. So we have used this technology since 2013, and the red bars is the number of lung transplant patients that we have been able to do using this technology. We use that technology also for hearts, so that's the green bar. So that's what we have been doing to keep our patients alive. Send the patient to subspecialized programs, ILD, pulmonary hypertension, cystic fibrosis, where those doctors are just dedicated to that disease. But also, then we said, let's see how we can increase the number of organs that we can harvest. And there are two technologies out there. There is a transmedic and the ex vivo. And let me show you. So, a lot of times we look at the information of the donor, lungs, x-rays, blood tests, ventilator numbers, etc. But then we go to look at the organ and we're like, I think this organ would work, but I'm not 100% sure. When that happens, we have to let go of the organ. Even though we felt that, oh my God, I think this would work, if we're wrong, the patient will die, the recipient will die. So now what we do is, this is the transmedic where we can put the lungs into that machine, and you can see the lungs are connected to blood supply, and there's a breathing machine, so the lungs are inflated and they're kept alive with preservation solution. And then we can keep the organ alive for about 8 hours. This is the other technology, it's called the ex vivo. It's a futuristic kind of fun stuff. But this is a cupule where you can put the lung in there and then connect it to the machine, to the heart lung pump. You can see this is the blood vessels connections, and then the breathing machine is on this other side. And you can see that we can test the lungs, we can look inside the lung, we can look for abnormalities, we can take x-rays of the lungs. So, and this is a real lung where it deflated right now, and the surgeon put it in and connects it to the machine. But that allows us to look at the organ and say, this organ that I was not sure if it was going to work, now I can connect it to this equipment, and now I can test how's the oxygen, how are the pressures, how is it that the lungs are looking, are they getting better, they're getting worse, and then we can decide, yeah, this organ could be used, let's use it, or not. That organ, I was worrying, you see, thank God I did not use it because it's not working. Yes, Tammy?
Is it this machine, or maybe a different machine, that if you find something wrong with it that's fixable, can you fix it with this machine?
So Tammy is looking into the future. So right now, we're using this machine to see if the organ can be used or not. But what she's saying is, Dr. Torres, but I know you. What you want to do is fix organs that they were damaged. Imagine now, if you have a small pneumonia, you could give antibiotics at very, very high dosages that if I give it to a human being, I would develop strokes, or I would develop seizures, or kidney damage, etc. Well, I don't have to worry about the kidneys. The kidneys are not there. I don't have to worry about the brain having seizure. I don't have to worry about anything else other than, can this antibiotic damage the lung or not? And organisms, bugs that are resistant at certain level of medication, now the medication dose is so much higher it can kill it. So you can start thinking about, whoa, this opens the doors to fixing organs. Blood vessels that were damaged, I can fix them, or etc. And yes, that means right. I'm looking into the future. How is it that I'm going to fix organs rather than does it work or doesn't work? This is the ex vivo team. Pietro is our surgeon. We have 5 nurses, and then me and a consultant. And it's true, sometimes it's frustrating. Things that should be working and they're not working, and sometimes we go out and have fun in restaurants, and it's kind of So some highlights. Over the past 5 years, we're in the top 10 number of transplants done, ranking in the nation. Our time to transplant is about 2.5 to 3 months. Obviously, some patients have to wait longer because they have antibodies, etc. Others, it's very quickly. But on average, 50% of our patients get transplanted within 2.5 months. We passed the 500 lung transplants last year. And we got the bronze medal, so 2012. But the reason we do lung transplant is to help people, like Mr. Gideon. He's an architect in Fort Worth, and in Christmas Eve he got the lung transplant. Patients like Mr. Young, he was the second lung transplant done at UT Southwestern. He's still alive 20 years after. Whitney, Courtney White. She was the first patient that we put into that little ECMO, the tiny machine, and we got her walking in the unit because the machine is now so small that you can walk the unit, and now your muscles stay strong and you are not getting weaker while you're waiting for a transplant, even though your lungs are completely destroyed and cannot keep you alive, but the machine can. Sanders, His only wish was, I want to walk the aisle on graduation day. He had the transplant in April. In June, he walked that aisle and got his diploma. So, over the past 5-6 years, we have increased the number of transplants that we have done at UT Southwestern. We have been doing between 60 to 65 non-transplants. We estimate being in the 70 range this year. We are about number 8 in volume in the past 3 years. Our 1-year survival is about 87%, which is average with national average. But you can see the company that we have, like Dio, Cleveland Clinic, etc., that we are on the top 10 of the nation. So over the past 2 decades, there have been many improvements in technology. Our survival for lung transplantation continues to improve. The lung allocation score is what has allowed patients like you with lung fibrosis to be able to get a lung transplant, while 20 years ago it was not feasible. You were not identified having the disease to be able to be placed active in the waiting list. And obviously there are many variables that can affect our survival. But the number, how many transplants that institution is doing, is extremely valuable because it makes the whole team be in sync. Okay, any questions, guys? Yes?
It's not on that. The other night, my wife's tube became disconnected. I was a pilot, and I know when you go up at an altitude and get without oxygen, you get hypoxia, and there's no way you know it. Is there a danger of that occurring in this?
Absolutely. If she's staying still, she probably may not feel that she is needing more oxygen. She was trying to go to the bathroom. She would be blue and she may even pass out. But a lot of times after a while she will feel that I don't have enough air. What's happening? What's wrong? Her hands would start getting purple, the lips, and then suddenly she said, hey, Hosby, can you help me out? There's something off.
I was awake, and all of a sudden I thought, why do I feel so dizzy?
Yeah.
You know, and nothing made sense, and I just didn't feel good all over. It was just, and then I realized, but when you wear this so long, it becomes like part of you. You
Absolutely.
don't really feel it.
Yeah, absolutely. Remember, technology allows us to increase our survival. Oxygen, we take it for granted. 30, 40 years ago, oxygen didn't exist. We would not be around. It's just, you need oxygen to stay alive. So if we could not give you oxygen because it did not exist, the life expectancy of your body, it was past and you would die from low oxygen. Nowadays, it's just something that we take for granted. Oh, you are low on oxygen. Here's a little tank and we increase it to 1, 2, 3, 4, all the way to 15 sometimes. But that didn't exist before. Your body needs oxygen at higher levels when you have certain diseases. Yes?
On the internet, every now and then you see something come through about things, working on things like stem cell or thermal procedures or something like that. Is there anything like that that's looking promising 10 years from now?
Well, down the line, sure. Today, you can send the check to me. I'll take it and put it in a bank account. Technology is not there. Stem cell, what's the next word? Research. It's not prime. It's not prime. And if they ask you to pay to get it, I can tell you there's so many other places where we can use that money for. And you will not be the first one who said, yeah, I tried it, I didn't want to tell you, doc, but yeah, I wasted all that money. you are a population who are at risk of being convinced very easily of giving you hope. I have this little pill. Don't tell anyone that I'm giving it to you. It's a miracle. It's a miracle, Eddie. But promise me you're not going to tell anyone. It's very expensive because, I have to do all these little things to be able to just make such a small amount of it. But don't tell anyone. I'll give it. It's cheap. It's cheap. It's only $20,000. If you want, I can have this guy that used it, and he's doing so much better. Talk to you.
There was an episode of Star Trek where they go back to San Francisco, I think. He's into a hospital, and the doctor sees some guy with gurney. They say he's in there for lung transplant or kidney transplant. He takes out he should take this pill. And then they go on,
Yeah, I wish we were there. We are not. I'm hoping that we will get there. I didn't talk about all the research that is going on. Instead of using human lungs, imagine if we were able to change the DNA of a pig. We can grow pigs to adult size in 6 months to a year. So you have fibrosis early on. I could start working on raising a pig, changing the DNA composition of their lungs, so that in 9 months to a year, I sacrifice the pig, take the lungs, put them on you, and since it has your own DNA, you don't need immunosuppression. That's kind of cool. Or, I have this patient who passed away, and I take the lungs out, and I kill all the cells, all the human cells. So I live like, have you seen when you dry fruits, you see kind of like the scaffold. You have all these little fibers. Well, if you do the same thing for the lung tissue, you take the lungs and you denature it, take all the DNA out. Suddenly you have the scaffold. And now you take some stem cells. You put them there and it populates the whole lung. And now, if I use your own cells, I can then take your bad lungs out and put these new ones in, and I don't even have to immunosuppress you because it's your own tissue. That type of technology is being developed. And we're closer. It's just all this stuff takes time. 10, 15, 20 years, but it's so much closer than 15 years ago when I started doing transplants, or 20 years ago. That I have more hope than this little, I'm going to spin down your blood and I'm going to infuse it back to you. What the hell? Those cells were there before. They were not doing squat. Why are they going to do something now? And it only costs you a bargain, Eddie. It's a bargain. I'm going to help you. Yes?
Some of us feel that the lung transplant itself is a hope for our future.
Yeah, the difference is I will always tell you this is not a cure. And Linda can talk about it. It is not a cure. And that's the difference. I'm not selling you bad hope. I'm telling you the life expectancy is 6 years. 50% of my patients will be alive at 6 years. And I cannot tell you if you're going to be one of those who is going to be alive at 1 month versus 10, 15 years. But if I had 100 of you, 50 of you would be alive at 6 years. That's the difference. These people are not doing that.
Anything specific in a patient that determines whether they get one lung or two?
And that's a great question, Esther. So there are certain conditions that you can only have 2 lungs. If you have pulmonary hypertension, you can only have 2 lungs. Otherwise, when we do this surgery, it's over 20% mortality at 1 month. Well, I cannot take that phrase. I have to do 2 lungs. If you have infections in your lungs, I cannot just take 1 lung out and put 1 in and then leave the infection on the other one. So I have to do 2 lungs. If you're a younger person in the 30s, 40s, or 50s, I want to do 2 lungs because you're young enough that you may want to be running marathons. Linda just wants to keep up with her drinking. 1 lung.
I was gonna have 1 lung, and like, in February, I had double pneumonia, and they went the other way. And then I wanted to see my grandson graduate. He did, early, and he's working his first job, and the next granddaughter got a full scholarship for next year.
Good.
So that's 2, 3 more to go.
But those are things that force us into 2 lungs. Patients with emphysema, interstitial lung disease, we can do a single lung, and sometimes we do that. But more is not better, it's just different. I want you to keep that in the back of your mind.
And like you were saying, that you're not healed. You're free because you don't have that oxygen. But you need to beware and don't get like right now in the middle of the move. I haven't been wearing this like I should all the time. You know, and you have to because I've had, 2 setbacks. You know, I had to go to graduation in Arizona, and I kept this on, but you get in a terminal, you get in, and someone or something, even though you carry your wipes and everything else, and then you get another setback as it's when you reach your side effects of some meds, that's standard. So you have a week, 10 days, 2 weeks that you feel like, oh, I gotta go again, I gotta start again.
You have to be careful
And
around
you know what
kids and stuff.
You know what I tell her? I like you, but please, don't want to see you that often.
Plus you have to be careful around kids as well, because they carry diseases as well.
Yeah.
Absolutely.
And I only have the single lung myself, and which I'm doing fine.
But it's good. And sometimes you feel like you're insulting other people, but your close friends, your family, they know, like they stayed away for 6 months.
I'd rather have somebody upset at me than me dead because I suddenly got a bad infection. And those are not friends. Those are...
And you have to cherish it because somebody gave you a lung to keep your life going.
That's right.
Yeah.
Are we talking just a lung transplant, or is it a heart lung transplant?
So there are very, very few people who need a heart-lung transplant. As a matter of fact, in the last year, there were only 50 heart-lung transplants done in the country.
Okay, so you don't do that every time?
No, so for the most part, now it's just lung transplant. There are certain times that we have to do heart-lung. For example, we just have 2 patients in the waiting list that need heart-lung. But those are the minority. It's just, for certain reasons, we have to do heart-lung. Remember, we don't want to do heart-lung because now we can only help 1 person rather than 2 persons or 3 people. Yes?
This is just something, I have been taking Imran for 14 years. I went to National Jewish, and they put me on there. And then also taking steroids nearly the whole, always. Does that affect good or bad?
So it depends on how much prednisone you're taking. Usually we do not like it to be above 10, 20 maximum a day. And the reason is because your tissue becomes very friable. If you look at your skin, it's very thin. And that's because of all the steroids you have been using. So imagine the surgeons having to put together it makes it hard. But as long as you are not taking over 20, we tend to be okay.
And the Imran is Okay.
Yeah, the urine tends to be okay.
I just was curious.
Yeah.
What if, I have a lung transplant here, I'm doing really good, and I feel like doing everything. What would be the perfect environment? What could I do and what could I not do? Everything I feel like, or should I really limit myself?
What are the post requirements?
So what are the limitations? In reality, me as a doctor, I want you to be in a bubble. I want you to stay at home. You are not going to see anyone. But what kind of quality of life am I giving you? So everything is about the benefits versus the potential problems that can happen. So there are certain things that, come on, that doesn't make sense. That was stupid, jumping off the airplane. You know, do you need to do that? Going scuba diving. You know, changes in pressures, why? You know, but you tell me, Doc, I want to go to that Cowboys game. There are a lot of people around you who you do not know, and they could have an infection. Well, there's where you take a risk, a chance, but it's not like an outrageous chance. It's just a small risk. And you wear your mask, you wash your hands and don't shake hands on people who you do not know, etc. The higher risk is closer to transplant, the first year, 2 years, because your immune system, we keep it fairly low. Over time, we lower your immunosuppression so that you're able to fight more infections because your immune system tends to get accustomed to that organ. So over time, you're less immunosuppressed. But the risk is still there of developing the flu, of developing RSV, another viral infection, or developing pneumonias, etc. So we say, you know, you want to go to the restaurant, don't go at 7 p.m. when everybody's there. You go at 5:30, where there's almost no one, and you talk to the servers, hey, listen, I need to be in a corner where there's not that much traffic and not many people. You want to go to the theater, you go to matinee, you don't go to the middle of the night show where everybody's there. So you start being smart about things. So it's not, you cannot do any this or that, is when to do it, how to do it, what kind of risk are you willing to take?
The main thing being around other people, the infections that you have to watch.
For the most part, that's one of them. Obviously, you don't go to the farm and start lifting up dirt and all that fungi goes into your face and into your lungs. Dusts, you stay away from it, you wear masks when there are dust around, and those masks protect you to a certain degree, not too much. So a lot of things is common sense and not being silly.
Wouldn't it pay him to wear a painter's mask?
But it's so hard to be breathing through it all the time. Remember, it hurts at the beginning, it hurts to breathe because you have all the incisions. But again, I want you in that bubble where I control everything that goes in and out. But it's the quality of life. You will look strange with this mask. Imagine with a painter's mask.
But you can get cute ones if you want.
Oh, yes.
Did you say something about pets in general?
I did not mention pets. Dogs are okay. Cats have parasite called toxoplasmosis that can go to the brain, to the lungs, etc. So we tend to stay away from cats. And if you cannot live without the cat, then somebody else has to deal with the litter box, etc. Birds tend to be a problem because people tend to be allergic to birds and cause lung fibrosis. So we tend to say no. Other pets like lizards, etc., rabbits, stay away. Yes, Tammy?
Rejection.
So,
After transplant, does everybody go through it?
So everybody, for the most part, will have an episode of rejection. 70% of patients will have a rejection the first year. That doesn't mean you lost the lungs. It just means that your body recognizes that your lungs don't belong there and is trying to get rid of it. That's why we give you that speedometer to take home and blow into the machine, so that when your lung functions are dropping, we are able to say, whoa, there's something happening. You come and we give you medications to stop the rejection. Most of the time, we stop the rejection there. Sometimes it doesn't. It can continue to progress, where then suddenly we start having multiple rounds of hospitalizations, start needing oxygen, and eventually it can cause you your death.
Okay, one more question and then anybody else have anything?
I was just gonna give him a compliment.
Go for it.
All right.
Because he deserves a bunch of them.
I was at your clinic on Friday for my first initial visit. And I'd already been hearing from everybody at rehab how great everything is there and how perfectly it's run. And I want to tell you that I wasn't disappointed at all.
Thank you. It's a lot of people. It's a lot of people. This was not built in one day. It has taken years. And I can tell you, it's a lot of people working for you all have a good experience. And believe me, we listen. And if you have recommendations, give them to us. Things that can be made better. If you have a problem, what kind of solutions? Because sometimes we don't think of that type of solution, and it's a good idea, just we didn't think about it. But yes, we have a lot of people working so that you all have the experience that you deserve. Yes, Linda?
And each one of them makes you feel like you're the only patient they have today. And they're always running like an hour, load of people, but that, and they have great coffee on the 6th floor.
All right, thank you, Dr. Torres.
Thank you, guys.
Thank you. I was supposed to tell you all beforehand, but we had Dr. Torres' permission and our director. Let me introduce you to my boss. All my bosses were here. This is my boss, Gloria. I'm putting her on the spot. Hi, Gloria. And then we have the purple, and then we have Edna, which is one of our respiratory therapists. She's spoken in the support group, and then Dorothy, also one of our respiratory therapists. I was thinking of an idea when Dr. Torres was talking, and I think I talked to Tammy about it at some point. Tammy was my first transplant patient that I had when I first started doing pulmonary rehab, so we've become pretty good friends. I have an idea of, because we've had, Fred, 3 patients transplanted in the last 3 months?
Yep.
It's been unreal.
Yeah, it's been unreal. I accused Dr. Glazer of having a hitman somewhere and like knocking people off to get these lungs because they're getting them very fast. Fred and I have both done pulmonary rehab. Well, she's done it longer than me. She's got a few years on her.
All right, stop.
But, I mean, can you remember when they were waiting 2 years? And,
yeah.
And then, I think after Billy, then we started
Billy
using
almost got kicked
transplant.
off because he was doing so good.
Yeah, he got so good. But here's an idea I have, and I may need some volunteers, is maybe doing like a panel. They do have it a lot in Dallas, but for our folks in our area, and getting a volunteer of those of you that have received a lung transplant, and then having those that are considering being evaluated, okay, that maybe you're seeing the UT docs and it's being tossed around that you may go that direction, and if you're interested in then having a meeting just for those folks. Does that kind of sound like a plan? I've got some people in mind that I think would be good. Dr. Torres did great at answering our questions, but sometimes there's stuff that maybe we want to ask, and I don't know, it's one of those things. So if I could, I'll get some volunteers to do that, and maybe we'll try to, I don't know if we'll do it before the end of the year. It's kind of tough. So another thing with the facilitating the COPD support group, the Better Breathers Club, and the Pulmonary Fibrosis support group. Yes, the diseases are different, okay? But the common goal is that we want to be support for each other. If anything, just to just have a ear, somebody to talk to, somebody to vent to. when we have limitations in our life, it's kind of hard to deal with. We're not only getting older, but now we're dealt with health issues that are causing limitations. So there's something magical that happens when you put people that share that common thing in the same room. So I think it's important to keep both groups together. So we will either have a Thanksgiving meeting or a Christmas party. Changes have come down the pike, and so, you know, we're having to kind of figure out where we can fit everybody. So I have most of all your emails, so what I'll do is I'll send out like an email, and then you can kind of vote, and you can tell me which one or the other. Okay? Fred and I try to kind of do a lot, but then it gets kind of tough too, so, but we'll figure it out, right?
Yep.
Right? All right, we'll figure it out. My mind's always working. Anybody have any questions? What a great, I learned a lot. So many notes.
They have a support group at UT Southwestern.
Yes, they do.
Every time
Can I
a year,
get some
every 2
detailed
months.
information about
It's a
that? and
transplant
maybe-
support group, and you can really get some good information.
Okay.
What do they mean?
Can,
Twice a month, every other month.
Every other month.
At
They
UT?
met this, yeah.
do you know who the contact person is? We'll talk.
Man, that's hard to
We'll talk
find
at
out.
some
Yeah, I'll
Okay.
look that up.
Okay. I can find out.
Curious, very fun.
Maybe. We can find out. Yeah, we can find out.
It's on the back of the door, the office,
Do you know who the point of contact is? Okay.
there's a number on there.
Anybody can ask their coordinator.
Okay. Do you want me to? Okay, great. Great.
Yeah, well, just
Yes,
give
ma'am.
the number too. Are you born with pulmonary? I'm sorry. Fibrosis?
Are you
No.
born with it?
No, very few people are born with it. There is a genetic form,
Oh.
and some patients will develop pulmonary fibrosis at age 30, 40, 50. But you tend not to be born with it. For the most part, it's an interaction of your body with something environmental and triggers something into your body that causes the scarring of your lungs.
What about cystic fibrosis? Is that,
Those
are you born
ones-
with that?
Those ones are patients who develop a mutation, or they are born with a mutation in their genes that causes a protein not to work well. And from early young age, they can develop pneumonias. And then that's why by age 20, 30, their lungs have been damaged significantly. But there are some patients with cystic fibrosis that they go along at age 50, 60, and then suddenly, by then, they get killed.
Do you feel like this is an inherent, I just want your opinion on this. Do you think this is something that can be inherited?
Well, you are probably predisposed because of your genetic composition. It's just unless you are exposed to that particular particle, then you don't develop. For example, there are people who got exposed to asbestos and they didn't develop any problems. Their genetic composition was such that it didn't matter. They were not. There are people who smoke and they were smoked like a chimney and their lungs are fine. And there are others that go leave. They only smoke a little bit, and by age 30 they need a transplant. So their genetic composition is such that smoking affects them significantly, while other people it didn't do much.
Asthmatics?
Asthma is a reaction to something in the environment for the most part, and then sure.
And alpha-1, we've talked about that because that's what I have, is alpha-1.
And alpha-1 is a genetic disorder, and you only need to smoke a tiny bit, and boom, your lungs get destroyed. Yeah. Okay, guys, it was wonderful.
Thank you.